small cell lung cancer. So I think we are moving from one type of lung cancer to other type. So what exactly is this small cell? So as the name implies, the cell is very small when we see on the microscopy compared to the adenocarcinoma or the non-small cell which we see. So whenever we see someone who is presenting with symptoms of lung cancer, what are these? So most of the times they present with either cough which is not subsiding, breathlessness, chest pain, or at times some manifestations because the tumor has spread to some part of the body. As was discussed with the earlier talk, the non-small cell variety, we see lot of mutations where we have worked for the AI, the NGS platforms. So we have a lot of work which is being done in the NSCLC. Unfortunately, SCLC is a malignancy which is very primitive. It is still somewhere the staging system is what was done in the independence era. So it was formulated in 1950s. So still we have not moved much in the small cell lung cancer. The reason being it's a very aggressive cancer and still we are unable to decode why it's so aggressive. So that was the past. And what we are going to discuss is what is happening right now in this small cell lung cancer. So lung cancer, all of us know that it's a leading cause of cancer-related death worldwide, even in India. And we can see that if you are seeing 100 cases of lung cancer, 15% odd will be small cell lung cancer. So the fraction majority is the non-small cell variety. The variant which we are discussing, small cell, is only 15%. And fortunately, most of them are seen in smokers, so we know why it is happening. So if someone asks, why did we get a small cell lung cancer, even if they deny that they ever smoked, we can tell with assurance that yeah, at least 97% they might have smoked sometime during their lifetime. And being a smoking related cancer, carcinogen induced, we see the population being in the elderly age, where again giving more drugs is challenging. And because it's an aggressive cancer, we see it spreading to the brain and other parts of the body, so a bit aggressive compared to the non-small cell lung cancer. And this is from our country, a North Indian analysis of the small cell. So we can see it's almost, if you are seeing the small cell lung cancer, we are seeing majority of them presenting in an extensive stage. I'll be telling about what's the stage. So it's like the advanced stage. So very few, only 1/4 give us an opportunity to treat them in the limited stage or the early stage. So why is there an unmet need in limited stage small cell lung cancer? So for this reason, because as I said, the survivals are very much dismal in small cell lung cancer. As we can see, I think we have patients who have crossed 10 years plus with the non-small cell lung cancer, mainly for the mutations they have. We have seen the EGFR mutation, we have the ALK, where we are seeing patients crossing even 10 years. So it's becoming more like a chronic disease. But if you are seeing the small cell lung cancer, patient will be very happy in the first 3 months. Once you start chemotherapy, the distress they come within 3 weeks, they'll be totally fine. They feel, why are we giving chemotherapy? That's a dramatic response we see in small cell lung cancer. But unfortunately, it relapses. We see the recurrences very fast. And we can see that the median survival is hardly 2 years for this even limited stage small cell lung cancer. And though we treat majority of the patients with radiation and a combination of chemotherapy, majority of them do relapse. And the reason, it's an aggressive cancer, and once it relapses, we don't have many options for this group of patients. So for this reason, we are still in search of drugs, and that's where probably our next talk will be taking about. And we can see that this, even if you are giving radiation, the recurrence is almost 60% in the area where we are giving radiation. And if you can see, even we have high number of patients having brain metastasis. So the classification, I think I already said, we have the TNM staging, which is very much updated. The recent one was in January 2025. But for small cell, we still use the veteran lung cancer staging system, which was actually formulated in 1950 and still is tested even today. The reason that it's very simple. So you can see, if we are having one cancer which is limited to one side of the lung, which can be treated in a radiation port, we call it as a limited stage. But if we see it has spread everywhere, we call it as an extensive stage. So that's the difference between the staging for the small cell lung cancer. And how do we treat? for very early stage, that is stage 1, surgery can be an option, but even though they undergo surgery, we still have to go for adjuvant chemotherapy and radiation for majority of the patients. So for that reason, most of the times we see patients opting for chemotherapy and thoracic radiation, where the chemotherapy will be for 4 cycles followed by radiation. Extensive stage is something which has already spread, so where we'll be talking about the newer evidence with IM4 and Caspian, where we have the role of immunotherapy again in this type. So concurrent chemoradiotherapy is the present standard of care in limited stage lung cancer. So this was what was taught to us when we were trained in 2010 or so. And even today, I think if someone is coming with a limited stage lung cancer, we still are doing the same. But what has really changed is with this data where we are going about this new drug from the AstraZeneca. So these regimens, why are we going to discuss about the practicality and usability of the newer regimens? Though it's a limited stage, we can see that what we usually do is we start off with radiation, which usually is given over a time frame of 3 to 4 weeks. And with radiation, we add chemotherapy because it covers the area where the cancer is affected. Post that, we try to complete the 4 cycles and see what has to be done. And we have something called as prophylactic cranial radiation. What happens in the small cell lung cancer is most of the times we see this spreading to the brain and they present with symptoms of brain metastasis. Because the incidence of brain metastasis is very high and the recurrences are there, we prophylactically give radiation. Even though we don't see any disease, we start radiation for this population subgroup.